invite John Laird back to the podium, our medical director of our vascular center. He's going to talk to us about new aortic technologies.
Thanks very much, Bill. I was hoping to avoid overlap with Royce, so I wanted to focus this discussion on abdominal aortic aneurysm devices, and I hope that this discussion would dovetail nicely with the presentation that Dr. Moore gave earlier this morning. These are all of my disclosures and not really relevant for this particular presentation. So there have now been 7 devices that have been approved by the FDA for EVAR. One of these devices was removed from the market. The AnCure device was taken off the market because of excess complications associated with the deployment of this device and problems with limb compression and need for multiple stents in the limbs. The most recent addition to the armamentarium was the Endurant graft from Medtronic, which we'll show in a little bit. And there have been a number of improvements and iterations in these devices over the years. There have been increases in the sizes to allow us to treat larger aortic diameters up to 36 millimeter grafts in some cases, increases in the iliac limb diameters to allow us to treat and get better seal in some ectatic iliac arteries. There's been some modifications of the graft material with a couple of the devices and modifications of the delivery systems in a few cases. 3 of the devices have suprarenal fixation, the Zenith device, Talent device, and now the Endurant graft. But they're all still relatively large devices. The smallest delivery system, 18 French, with the Gore excluder device, and many of the devices still in the low 20s in terms of their French size. So still plenty of room for improvement in that regard. And we'll talk about some of the newer systems and lower profile devices. In terms of some of the other iterations or things that are evolving, Cook has a lower profile endograft, which is available in Europe and in investigation in the United States. Fenestrated grafts we'll talk a little bit about. There's a new delivery system for the Gore excluder device. And Endologics is introducing a fenestrated off-the-shelf graft as well. This is the Zenith Low Profile device. Looks very similar to their current device with some modifications of the suprarenal fixation stent and the stents themselves and graft material. I'm not exactly sure how they were able to squeeze around 4 or 5 French out of this in terms of downsizing, but they now have the ability to deploy the stent graft through a 16 French delivery system with the typical double trigger wire release mechanism. So it looks very similar to the current delivery system. So hopefully we'll have this available to us sometime in the near future. This is the new Gore excluder delivery system. The simplicity of the excluder deployment mechanism has always been attractive, just basically pulling that ripcord and then the device deploys in seconds, but there was always a little bit of lack of precision in terms of that mechanism, the potential to lose a few millimeters as it deploys and drops down below the renal arteries. So this was Gore's attempt to make their device delivery a little bit more controlled and precise. With the new handle, you can basically deploy the graft while maintaining the proximal aspect of this graft collapsed so that you can shift the device proximally or distally or rotate the device as necessary. And then when you're sure you have it nailed right below the renal arteries, then you can go ahead and deploy the proximal aspect. So a lot more controlled than the original excluder mechanism, delivery mechanism. So you can deploy the trunk device past the contralateral gate as shown, constrain the leading edge of the trunk device to 30% of its full diameter, reposition as necessary, and then go ahead and deploy the rest of the graft. This is Medtronic's latest stent graft, the Endurant graft, which was just approved this past year. If you look at it, it looks actually quite a lot like the Cook Zenith graft. There were significant improvements made, though, in this device compared to the Talent device and the Knell X device. A new or a different suprarenal fixation stent with better active fixation, a better delivery mechanism, which is again maintains a proximal constraint of the device until you're absolutely sure you have it in the place you want to deploy it, and better stents and support throughout the length of the graft. So a significant improvement, I think, over the Talent device, and now very competitive with the other devices that are on the market. But given all these improvements, we still can only treat roughly 50 to 70% of our patients with EVAR, depending upon how aggressive you are in treating some of the patients with borderline anatomy. And the most common reason still for not being able to treat patients with EVAR is inadequate proximal neck morphology. Some patients will not have adequate seal zones in the iliac arteries, and then a small percentage of patients cannot be treated because of very diseased or small iliofemoral vessels. So potential solutions that would allow us to treat more and more patients with EVAR would include recreating a better proximal anastomosis or fixation. One potential solution would be a endovascular stapling device. We'll talk a little bit more about this. To move the fixation to a visceral segment of the aorta, where you have more stable fixation, basically in patients who have an inadequate neck or a juxtarenal aneurysm. And that basically we're talking about fenestrated or branch devices. And then lower profile devices to allow us to get access in patients with diseased or small iliofemoral vessels, and branched or bifurcated grafts to allow us to get a seal in the iliac arteries without having to exclude the internal iliac arteries. So this is a partial listing of some of the newer devices that are in investigation or potentially available outside the United States for use in these patients with complex anatomy. Fenestrated devices we talked about. We're going to spend some time talking about the trivascular device, which is in study in the United States, and we're one of the sites in this trial. Terumo has their Anaconda stent graft. There's a smaller company called Lombard Medical, which has a graft with some proximal active fixation. There's the Aptus modular endograft with endovascular stapling. Talk about the Knell X device, which was recently purchased by Endologics, and then a few other disruptive technologies. So this is the Ovation abdominal stent graft system from Trivascular. It's about in the middle of enrollment in their United States prospective registry. It's a tri-modular design, has suprarenal stent with anchors for better fixation, and inflatable rings for trying to get a better seal below the renal arteries. And we'll show this better in a little bit, but basically these rings are filled with low viscosity radiopaque polymer. One of the really nice features about this device is its low profile. A 14 French outer diameter aortic body can be delivered without a sheath, a separate sheath, and 13 French for the contralateral iliac limbs. It's already been a CE marked and available in Europe, and as mentioned, under trial in the United States. So as we talked about, the smallest device currently available in the United States is 18 French. The trivascular device, 14 French, makes it much easier to do the procedure totally percutaneously. There is the active fixation proximally with suprarenal stent and anchors, and then these sealing rings below the renal arteries in the proximal aspect of the main body of the graft. This polymer-filled sealing mechanism provides for a watertight seal, and then potentially could allow treatment of patients with even shorter infrarenal necks, down to as small as 7 millimeters. And in the trial, we are allowed to enroll patients with an infrarenal aortic neck of 7 millimeters or longer. Sorry for the advertisement here, but we'll just take you through a brief video showing you the trivascular device, because I think it is an interesting technology. So this is the 14 French delivery system, hydrophilic coating. Again, there are markers that allow you to rotate the device and align it as you wish with regards to the contralateral limb. You can deploy the proximal stent partially, reposition, getting orthogonal to the proximal graft so you can line it up appropriately just below the renal arteries. Do your positioning angiograms. Then go ahead and deploy the graft. And once you've deployed the graft, then you can prepare your polymer for injection into the device. There is an automatic injector that actually is quite easy to use. You just hook up to the port on the graft, and the automatic injector will inject this polymer, which we see on fluoroscopy. You can see the rings basically fill from the ipsilateral iliac up into the main body and then down the contralateral iliac. As the polymer is delivered, you wait around 20 minutes for it to solidify. While you're doing that, you can gain access to the contralateral gate and then go ahead and deploy the contralateral limb and then the final ipsilateral limb. So it's a very simple system, very easy to use, potentially allow us to treat people with shorter necks, and certainly allow us to do these cases totally percutaneously. One of the other very interesting technologies is the endovascular stapling technology. Again, trying to allow us to get more secure proximal fixation that could potentially approach what we achieve with an open surgical repair of the aneurysm. This is the Aptus system. They basically have the endostapling technology, but also had their own proprietary stent graft. Unfortunately, it turned out this stent graft had problems in the initial U.S. trial. They had a high rate of limb thrombosis and thromboembolic complications, so the trial was halted. They've since now modified the graft. It's available in Europe and will be starting back in trials in the United States. The endovascular stapling component of this system is available in Europe for use, and the company is looking to hopefully get this approved in the United States separate from the graft so that it can be used in conjunction with some of the other commercially available grafts to allow for more secure fixation in patients with tenuous infrarenal necks. So this is what these staples look like. They're really little screws, 4.5 millimeters in length, 3 millimeters wide, made of nickel cobalt alloy. They can be delivered into the aorta through the stent graft with this delivery catheter, and very strong. Some of these measures don't really mean much to me, but in terms of how it would compare to a standard suturing of a graft and an open repair are very similar. So this is how they're deployed. Typically you would deploy 4 or 6 per graft with this delivery system. They're just screwed into the wall of the aorta through the graft material. Fairly simple to do, fairly quick, and very secure once they're deployed. And this is the final fluoroscopic image, in this case showing 4 of these screws circumferentially around this graft. So hopefully sometime in the near future we'll have this available and have this capability to strengthen the proximal fixation in people with short or tenuous infrarenal necks. One of the other very interesting technologies, and perhaps one of the more disruptive technologies in terms of the concept, is the Knell X endovascular system. This is a small startup company that was just recently bought by Endologics. And basically it has the potential to solve the problem of a bad infrarenal neck, but also solve the problem of type 2 endoleak, which has really been kind of the bane of our existence with regards to abdominal aortic stent grafting. It consists of, the device consists of an endo bag basically that you fill with a polymer, and it basically just fills up the abdominal aortic aneurysm sac around the stent graft. So you have, again, this ePTFE endo bag that's filled with a polymer. Usually you'll use something that'll make it radiopaque during the procedure so you can see it, and then that will be dissipated over time. And then you have the stent graft itself is basically just 2 nitinol tubes, covered stents that the sac fills around. And this is what it looks like in a model once it's been deployed. The sac filled with polymer, completely filling up the sac and potentially preventing any backflow into the aneurysm sac through the lumbar arteries or IMA. And this is what it can look like in a patient. We see the limbs of the graft here, the typical nitinol stents with a graft covering, and then the filled endo bag and the final angiographic result. So a very interesting technology. Early, though, in terms of the investigation, have not started, I believe, yet their clinical trial in the United States. We could spend really probably much of the afternoon talking about fenestrated grafts and all of the snorkel techniques and chimney techniques for treating patients with juxtarenal aneurysms or complex anatomy. Cook has really taken the lead in this role in terms of the fenestrated grafts. These devices are available outside the United States. Limited availability in the U.S. at a couple of sites. The two main centers in the U.S. have been the Cleveland Clinic and UCSF. Basically just shows what the graft looks like, have the suprarenal fixation and the fenestrations for the renal arteries, as well as scalloping proximally for superior mesenteric artery. And the plan would be that they would have a wide selection of sizes and configurations, so hopefully you could have a graft off the shelf to treat your individual patient, but potentially if you couldn't, then you could order a graft based on the measurements that you obtain from your CD and your CT and your 3D reconstruction. So there is a widening experience with fenestrated grafts around the world, technically still very challenging procedures, but ultimately this is going to be probably the wave of the future in terms of treating patients who have no infrarenal neck, juxtarenal aneurysms, thoracoabdominal aneurysms, and the like. This is just an angiogram of a patient who had a fenestrated graft. You can see the renal arteries are patent with good flow. Typically use either a bare metal stent or more commonly a covered stent through the fenestration into the renal artery to maintain flow and achieve the appropriate seal. So conclude by saying that there continues to be significant improvement and evolution in our EVAR devices. We are going to be getting lower profile devices. We've seen and will see in the future better delivery deployment mechanisms and more secure anchoring and proximal sealing. These device improvements will lead to even greater procedural success and safety, more opportunity for percutaneous or totally percutaneous procedures, and I think a broader patient population that will be able to be treated. Thank you very much.